Hi, everybody. Thank you for your interest in the Align program, the high-risk geriatrics program we have here at Sinai. We've been through a lot of changes over the past several years, and we are excited to share where we are today and our updates and how we went through this journey. My name is Stephanie Chow, and the next slide, which I can get to, are my disclosures. So no financial disclosures. My DEI disclosure is that I'm a daughter of immigrants. I'm a mother of young children, and I'm a champion for diversity, equity, and inclusivity for my health institution and the patients and communities that we serve, which will become important when I talk a little bit more about our older high-risk patients and how we are trying to make an innovative program that will accommodate everything that they might need to be the healthiest and best quality of life for them. This slide is showing a very well-known demographic change over the past many, many decades. As we know, many decades back in the 1950s, we had the traditional pyramid in which the younger population was really providing a lot of support to care for the older. And there were not as many older persons. You were lucky if you were able to live past 60, 65. And when further inventions of hygiene and sterilization in healthcare existed, lifespan increased even more. And so you can see as over the decades, this aging population has shifted. We are learning how to be healthier, learning how to grow, live longer, participate more functionally and cognitively in our everyday. This shift has really expanded to a spool shape and then now almost like what I like to call an ice cream cone. The idea of this expanding population really shows you that this this phenomenon of aging is a major medical and social issue. It is a public population health issue. There's a lot of things that we can focus on: prevention of chronic disease. The WHO pushes for talking about chronic diseases, access to age-friendly primary care, and then also in general, creation of age-friendly environments. Because you can imagine as this is expanding, the older we are, we need to be able to adapt to the spaces in which we move. One of the things that we know have been causing this population kind of imbalance is the longer life expectancy that we have, and then also the decreased birth rates. And the goals for how men and women choose to have productive lives has also changed in terms of how family planning is created. So we know that the pace is increasing. The projected numbers of persons age 60 and older by 2030 is 1.4 billion. By 2050 is 2.1 billion. So this is equivalent to about 2/3 of the world's population by 2050 will be 60 years and older. And we really have to think thoughtfully about looking around our spaces and who we are taking care of. How are we going to be able to manage as more and more persons, every 2 persons from the 3 that you interact with will be 60 and older and with accumulating comorbidities and other health concerns. This creates a significant impact on all aspects of life, including families and communities and economies. And we have to really think about that when we're looking at healthcare models, which is why I'm here to talk to you more about what we have done with Align. So we know that every part of us is aging. Every part of our bodies, whether or not we like it. This is not necessarily tied to race or gender or ethnicity. These are not even linear associations. These are not always consistent, and it's loosely associated with age, but really the way that we practice our lifestyle and the way that we live really can contribute a lot, in addition to the environment that impresses upon us their own influences. We know that biomedically, by being a physician, I can talk to you clinically about what has been changing, but also what is much more attention being paid to is the aspect of psychosocial health and those social determinants that really impress upon a person these kinds of things that will also affect aging, other life transitions, retirement, milestones in your life, changes of your housing or living conditions, living environments, and even tragedies that have occurred in your life, such as deaths of significant persons, partners, or friends. You have complex health states, and the older you are, you accumulate more of these complexities, these chronic conditions that continue to progress. There are new opportunities, both living longer gives you new opportunities, both positive and negative, new opportunities for careers, further education, engagement of things that you had long neglected because now you have perhaps more time in retirement. And the extent to which a person can engage in this really has to do with how their health is. And so really uh, this proportion of your life, there's evidence that actually suggests that the proportion of the life in good health has actually remained about the same. And those additional years that we are acquiring by improving health technology and science is actually spent in poorer health, what we consider poor health. So really, we know that as healthcare is in at least the U.S. And for now, what we're looking at our older communities, it's not improving. We need to fix that. There is no typical older person. And so it is important for us to have programs that are flexible enough to adapt to the needs of the specific persons and their families, their caregiver and families. And while we know that not all older persons are frail, the risk for frailty increases with age. We have their older persons are perceived as a burden to society and also feel themselves that they are not valued. We know that as a society and public health institutions, we need to respond in a way that is much more supportive to our older persons through healthcare, through our infrastructure, in our home and community environments, and in general in our day to day. This need is taking a look at the idea that 5% of patients make up more than 50% of all medical costs. There was an actual various versions of these statistics are posed for many learners and healthcare, just to really have an idea that there is a small proportion of persons that make up for more of all the health expenses in the United States population. And if you look at the top of the pyramid, and this is where a line is focusing on, we're looking at those with the most advanced illnesses, those that have most of the medical costs, that we may be the most influential, simply because there are not enough of us in geriatrics trained fields to go and make sure and manage these older vulnerable patients. And we know that this diagram is looking at medical field things specifically, but we know that multifactorial psychosocial factors will also get us there and contribute to much of this healthcare utilization. We know that if you really drill down to this 5%, this costly 5%, who are these persons? Who are these patients? They are persons that may perhaps not remain high cost forever, truly, and there may be things about their health care, medically or psychosocially, that can be modified and prevented. And so the idea of focusing on these innovative model, unique things, ways of reaching out to patients from not just medical, but psychosocial realms is to really drill down and find out who are these patients and how can we make an impact on their care. We know that I actually have been showing this slide for quite a few years now, and I actually don't like it anymore because it's looking at people over 65 and women from 25 to 44 and ignoring the rest of the world that may be taking care of persons over 65. But we know that a long time ago, women between the ages of 25 to 44 made up the majority of the care gap. If you had an older person come into clinic and they came with somebody, most of the time, maybe 80% of the time, it will be a woman, and she will be between these ages 25 to 44. We know now that when I showed you the population pyramids, there are fewer of us in this time. And then also there are more, the things that women between this age are able to do now have changed. There are more opportunities to do things other than healthcare, other than taking care or being a caregiver and taking care of loved ones or of patients. And so while the traditional caregivers were often women, there are now women in other areas of the workforce. There are more opportunities. They're allowed to do different things. And so with these choices, the care gap actually has to be filled by everyone outside of this. So women younger, women older, or men. And so the idea that there will be caregivers who perhaps are coming into this responsibility may not be expecting to have the role of caregiving that will change. This will actually create a gap. It will be much more heterogeneous, the quality of care that is received for our older persons. So you have an older, frail person who really needs help. The idea of where that caregiver comes from, if it's not from their own family structure, it may be from an agency, it may be from something else, formal or informal supports, and the quality of that care may not always be consistent. So the idea of having caregivers who are anxious because they don't feel that they should be they're the right person, caregivers who are guilty because they just feel, they're the only one to do it, burned out caregivers who are upset or angry or frustrated. All of this will contribute to more problems in how patients are able to navigate these complex health systems that we've created. We know there's a shortage of the workforce in geriatrics. Those who are trained in care of older persons, we do not have enough. We know that we need more geriatricians, we need more specialists to take care of, sorry, we need more specialists who take care of older persons, family members who know how to take care of older vulnerable persons, social workers, therapists, geriatric psychiatrists. In terms of the social work realm, we know that there are more than 1 million additional direct care workers who will be needed by mid-20, but by the early 2000s. And according to the U.S. Bureau, only 7,000 certified geriatricians are actually practicing in the United States, with half of the numbers that are actually needed, and this number is falling. So within 10 years, nearly 70,000 geriatric social workers will be needed, yet there are less than 5% of social workers who are actually trained in gerontological social work. So by 2020, this nursing workforce is really expected to drop 20% below these projections. Also in 2010, physical therapists and therapist assistants had demonstrated that there was high vacancy rates in filling their programs in skilled nursing facility settings, and that only 3% of practicing psychologists devote the majority of their practice to older adults. And as you can see here in this graphic, you can see at least for medical residencies, geriatric medicine slots are not well filled, and we really need to do a much better job. So finally, onto our program, we have the aligned vision. We want to improve the health and quality of life for older persons living with serious illness and complex needs. Our mission for Align is to work closely with the primary care team to provide this added layer of support during a time of acute health crisis. So from the previous slide that showed that maybe there's a short 40% of our highest risk patients would have a temporarily kind of reason for being high cost and high utilization. We want to focus on that group of patients and figure out what it is that we can change. And so with that, we have our interprofessional team, social work, care coordinator, nurse practitioner, medical doctor, clinical, other care managers. We try to enroll patients within a concrete amount of time, maybe three months. It's kind of creeping up to half a year or a little more. And we really provide an added layer of support to this primary team during this acute health crisis. And we promote continued visits with the PCP as well. So we continue with the rapport. We have the fundamental thinking is that the primary care provider should be the medical hub. And we are this additional group that will support them. Because there are not enough geriatricians, we cannot be the central line. We need that primary care provider, but we also need to make sure that the patient and the provider feel that they can continue their relationship through their healthcare, through their lifespan, and maintain a high quality of life in keeping with what matters most to them. This is a spokeswheel model of the different pilots that we've engaged in. In the center, you have Align, where we started with this core group of team members where we do this interdisciplinary plan. We have stemmed into other branches. And so kind of looking at your healthcare institution, where are those pockets of need? Where are those places? Who is calling out for help? Who are champions of older frail persons in improving their care? And who has the resources and ability to really offer that support? So for us at Mount Sinai, we started with this intensive ambulatory care practice. We started inside the geriatrics clinic. And then we had champions in surgery who really announced that they really were realizing they were taking care of older patients. 30% of their patients were 65 and older. And they wanted to have some team to be able to help co-manage and assist alongside, mediate and modify some of these risks. We had mental health programs that were created also to support our older vulnerable patients. We had the emergency room asking for assistance with where do they send patients who don't have strong primary care links, and how do we improve that primary care bond? Transitional care management from the hospitalist teams for discharged patients was also a pilot that came from this Align model. The idea of having a flexible team that can pivot and really push at where are these needs for older vulnerable patients became really important during this time of growth and development. COVID was one of the biggest challenges for so many different places in healthcare, and just much more pronounced in our older vulnerable patients, in terms of looking at escalation of support, greater advanced care planning practices, looking at social isolation and home safety, mental health, and also the concept of telehealth platforming, which became much more important and much more challenging for our older patients. We are looking at recruiting and training the future of this country and in the world. We want to make sure that as our population ages, we have the workforce who can take care of them with the knowledge. And so the idea of creating curriculum for our learners was also an important piece. Other programs such as patient priorities care, community paramedicine, were also some ancillary programs that existed, and we formed collaborations with them to really study and see through how can we best support different programs with different aims. This is another schematic of how we were involved, and the idea of how we use our flexible team to really split some of these tasks and ideas of prioritization. I just presented this as different ways you might want to showcase if you were also practicing something and trying to spin off your ideas. So to start, we have our population Align and our resource-intensive interprofessional team. You include whoever you need to have on your team to really target and focus to offer the best services to your population. For us, it worked out as a medical doctor, a nurse practitioner, social worker, care coordinator, and an administrative associate. So the idea of having this balance between the medical side and the psychosocial side was very important for our care for our older high-risk patients at Sinai. We wanted to reduce unnecessary emergency room use, reduce how long patients stayed in the hospital, look at reduction of in-house morbidity and mortality, and overall look at the health system. What is the strain in the health system, outpatient and inpatient? Where can we really support this overall health practice? And furthermore, identify where are those healthcare inequities? How do we reduce these disparities and make sure that those who are not afforded those resources can get the things that they need in order to live healthily in the best way that they can. The table on the right, you can see some of our initial information, our demographics of our patients seen in the earlier years. These slides are quite old. This slide is quite old. Comparison to the geriatrics clinic, and you can see that our patients are ranging from a little bit in this way younger, a little more female, a lot more communities of color. These were referrals from the geriatricians, the primary care providers themselves. They felt that this group required much more assistance and support because they were not the resources were not the same, and they wanted extra support from Align. The language also was different from the geriatric team compared to Align. We had a lot more Spanish-speaking bilingual patients, and so the idea of having team members who are able to speak in Spanish, bilingual, was also much easier for the rapport that we were building for our patients who are vulnerable and often mistrustful of the health system. This is a diagram of the differences of how Align really expanded its care for those patients who need it the most. The typical primary care is probably what you're used to seeing in your office setting, quick visits every several months, or maybe even once or twice a year, maybe some telephone contact and social work. But you have the geriatrics team at the Martha Stewart Center, Mount Sinai, for example, longer visits, with a little bit more social work availability, and some even geriatric psychiatry at the time. And actually, after COVID, we don't have the specific geriatric psychiatry, but we know that there's a greater need, and there's always a need for more psychiatric and mental health care. And finally, Align. So the geriatrician or the geriatric trained medical provider, our visits are long, from 30 to 60 minutes. 60 would be the initial visit. 30 minutes is your follow-up. We can have our visits in the office, the home, or the community. When we were a smaller team, before COVID, we were able to do more home visits and actually structure visits around that and able to really go into a person's house to see that, to see the vulnerability, to see where the challenges would be. We actually even had visits elsewhere in the community, in the pharmacy, uh, or at the breast surgeon's office. So we were able to kind of have different spaces where we could meet patients, to really see how it is that they carry their lives, how they move through their spaces, and where their challenges are. Um, there is a 24-hour telephone hotline that we use in order to really reduce the communication barrier. In our initial needs assessment, patients had offered that they had a very difficult time reaching the clinician because they had to go through a triage person or a call center who didn't have familiarity with what they needed. And that was frustrating for patients. Or also there was a language barrier. And so, for example, Spanish speaking patients didn't feel so comfortable describing, or they didn't know how to advocate for for their needs. Uh, a line having a dedicated social worker and a care coordinator was also a key component of the power of this group to be able to support those psychosocial determinants, and knowing that actually for older high risk patients, the medical piece is a significant part because of those accumulating chronic comorbidities that we discussed earlier. However, the idea of the support, the caregiver burden, that caregiver gap, that quality gap that I had described before, these were also huge things. And at times, this is probably the number one thing that was really on the minds of our patients and the caregivers. How do we keep up with this care? How do I maintain all these appointments? How do I get there? How do I get that wheelchair there? There's so many things that really came up. And so the idea of having this psychosocial supportive team is essential. The idea of a fast-track geriatric psychiatry links to mental health also, if you have that available. We no longer have that specific piece right now because of, great thanks a lot to COVID. But the idea to try to maintain these relationships or these links, if you have it, establish these rapports with these groups in the community if you can do so. And then also links to 24-hour services if they are available. And so all of these things, thankfully for us during pilot phasing, was there for us to try and trial out and see what really worked. So the criteria for Align, they are rather loose. The idea of high risk for an older patient is heterogeneous. I mean, an older person is an older person, an older person. There is no uniform one older person. They are not all the same. They have so many things over many years that have caused this divergence and that homogeneity. So you have to know that the criteria for high risk is also as diverse as that. So the idea of, in general, health system definition of high risk, you can use that. High risk for hospitalization, ED use. That's really a very popular, common one for a lot of these ambulatory intensive programs. For us also, because of our hotline, frequent phone calls out of proportion to the illness. And that might actually also be a component of anxiety, but it also could be something like CHF exacerbations or COPD, things that kind of chronically recur or accumulate rapidly, and they want to have an immediate contact with somebody who knows them. They don't have to repeat everything all over again. Those who have concern for safety risk, those who are and caregivers who can't support them, they're falling at home, they're by themselves, they really make poor choices, and they don't have the insight. These are some criteria. Declining health with significant shift in baseline, having just in general something of their chronic medical conditions is worsening, and the primary team is not able to support this, and they foresee frequent hospitalizations. That's another reason to refer to a high-risk ambulatory geriatrics team. And poor patient engagement is another big one. That can be for so many different reasons. It can be for cognitive impairment, not being able to keep up with your appointments. You have no idea when the next visit is. You don't know how to write it down. You don't know how to organize that. That's one. You could also have a person who has been jaded by the healthcare system because historically the health system has not served them well. Perhaps they were victims of discrimination. Communities of color may feel that the health system has not been there for them. In the COVID crisis, we actually saw a lot of concern for the COVID vaccine and how it was administered to patients. And so this idea of poor patient engagement, they want to stay away from you as far as possible because of the history of what their healthcare experience has been. And the idea of trying to reach back and bridge that disparity is something that is very important for Align and its team members, because we recognize that our patients are not the same as the general Mount Sinai Health System population, nor is it the same as the general geriatrics population. We have a distinct population that is very, it's not that they don't want the care, it's that they don't trust you yet. And so that building trust is something that perhaps it requires a lot of time and that intensity that a high risk team such as ours could offer. And then finally, the vague category of rising risk. It's any of these above or just at a smaller degree where you instinctively, given your experience and just acumen, just feel it's going to be bad in a few months. And you know that it's happening, you feel it happening in your interactions, but you just don't know how to describe it. We can also take that because with the many different hats that we have in our team, the many different perspectives, there are some things in the care coordinator role, for example, or the nurse practitioner role where they might see something that they can offer that is not easily seen or readily seen by the primary care. And so really, this is the person, that the patient that keeps the clinician awake at night. This is what you can't figure out, how am I supposed to help this person? You could try sending them to a program such as Align, or whatever it is that you're going to build, because we need this no matter what form it is. For social, psychosocial, so we think of it in two parts, the medical side and the psychosocial piece. There are probably many ways to break it down, but this is how we've done it for simplicity. That idea of having this extraordinary level of support services that is needed, that is not present in the primary care team. When we did a survey of how many of our surgery co-management patients actually had a social worker in their office, the number, don't remember the number, but it was quite low. Many did not have a social worker or even knew that one existed. It is not a luxury that most practices can have, and if not, it may not be every day or with quick ability to be seen. Social determinants of health for older persons, that often is of concern. The economic stability, the ability to pay for some of these treatments, these transportation, these referrals, physical therapy, medications, even the home attendant care, if they do not have Medicaid. These are things that could increase a risk for an older patient. Level of education, health literacy, and just general literacy, understanding of what the instructions are saying, but also have a deeper understanding of how those instructions apply to your specific health, whether it be your physical health or your emotional health. Other social determinants such as your society and your community, what is the supportive structure environment around you, and then in general your healthcare, and then where you actually live, your neighborhood and built environment. And we know that studies have borne out, that hotspotting areas of where there are higher concentrations of persons that do not have the resources, food deserts or other things that they're lacking, that contribute to their trip into the emergency room much more frequently than other areas. And that's the person that the social worker also cannot sleep. So sometimes we don't sleep all that well, but for the most part, this gives a very satisfying job and way to care for persons who really need it. So this is just, I know you probably don't need all the detail, but our referral form, it has since adapted in different ways digitally. But the idea of the criteria based on what your social worker and care coordinator or your primary important key players need. You get your stakeholders involved, see what it is that they feel is needed. You ask your patients what it is that they need. And with all this, you have your referral form. So for us, it was looking at that loss to follow up, that ED visit, hospitalization. The need for care coordination is a huge one, as I said. Medications, this new medical condition that just cropped up and we don't know how to do anything about it. We don't understand it. We don't know it. Is it important or not? Caregiver support, caregiver burnout, that caregiver gap I was telling you about. So all of that. Concern for home safety, not being engaged in the clinic for maybe various reasons, including the ones I had said before. Worsening dementia, a large thing. And there, as I said, not enough geriatricians, geriatric psychiatrists, everything. So primary care providers are being forced to take care of those with dementia, and they may or may not be able to do that. They may not have the bandwidth or the knowledge and skills. And so referring to a geriatric intensive team could be the best. and then other psychiatric conditions. And then at the end, also because of COVID and now moving forward, the idea of telemedicine and optimization, the discussion of how do you get somebody in theoretically into your office space without physically getting in because of all the other barriers involved, transportation, physical function, cognition, all of these. And then also we added on the surgery co-managed as one of our pilots. So just ways of how you create a referral. And then also for the referral form has that medical psychosocial criteria, but then it also includes, you want to know a little bit more about that primary care provider and that relationship, because in the long run, having an intensive ambulatory team, it is because you are not able to be the primary care for this group because there are so many that need it. You need to free yourself up. So you are a temporary program with several months where you work with the primary care provider. You need to be able to transition that patient back to their primary team and do it well so that they don't default back to you. This is, in speaking with other high-risk programs, one of the most difficult things is to graduate the patient. So what you need to know is the background from the PCP. So you want to know what is their adherence to your care plan, the PCP. You want to know if the patient this is the PCP's perception. You want to understand actually how much the PCP knows about the patient and also what they perceive about the patient. What is your patient's understanding of the care plan? How motivated are they? How involved is the caregiver? Are they making it to your appointments? What is your own rapport? And what is your level of provider burden and stress? So these kinds of things. Do you think that this is, what is it that you're trying to tease it? Why do you think they're high risk? In addition to those medical psychosocial things you identified on the earlier slide. What's your concern that this patient's going to have decline in functional status? What's your concern they're going to go to the ED? And then the hospice surprise question that my department loves is, if the patient dies in the next 6 months, how surprised would you be? So we really are kind of using use your referral that you designed to kind of get at those kind of questions that you need to take better care of your patient, be able to eventually graduate them in a long-term way. And then kind of think about those curiosity questions that you just might have, those clinical questions, because this is an exciting experience. When you're designing and creating a high-risk program, you want to be able to offer, filter in and be able to get the answers to the many questions, the clinical questions, operational questions that you may have. So the Align intervention has supposed to be 1, 2, and 3, not 1, 1, and 1. I think that's the formatting, but the visits, the hotline, and then those team meetings. And there's probably a lot more, but for simplicity, this is what we've done. So when a patient is enrolled in Align, they have, well, actually before that, the primary care provider, the PCP, or the hospital team, or the specialist, or the emergency room social worker, anybody will identify this patient. From your medical hat or your social work hat, you'll be able to say, I have all these fears. I can't sleep at night. These are the things that I'm worried about. Let's send this patient to Align and let's make the referral and fill it out. So they identify the patient, they make the referral, and then we review that as a team at the huddle. We decide, will we make an impact on this patient? Should we take this case? Most of the time we take the case because your instincts are usually pretty good. And for the most part, this service is very much needed. The care coordinator will outreach the patient and she'll establish the visit. She'll do that. And there will be communication back to the PCP. Again, we want to continue with that relationship with the PCP. You have the initial visits for the social worker and the medical provider. And then the team comes together again to create the plan. What is the long-term plan, the short-term plan? What are the steps to getting there? What are our goals, our concrete goals? What are the modifiable risk factors? So we have our series of follow-up visits, and each time there is an assessment, a reassessment, a huddle about where we are in the care plan. And then at the end, the achievable modifiable goals are achieved. That's the hope, or at least most of them, to a point where they can be stabilized and go back and see their primary doctor. There is a communication of, are you okay with you continuing and taking back your patient? Is this patient stable enough? And then we have another visit to kind of close the relationship with Align, and they return back to their primary provider. With this, the idea of graduation, like I said, it's difficult for many programs to graduate their high-risk patients because they have been seeing us for so long, so frequently. So the idea is to always insert that idea. We are just a temporary team. Your PCP has seen you, and they are happy with how things have progressed. And so We don't schedule further visits, but we do chart review, especially if they are in our health system. And the idea is to look for red flags to really support the primary team for a period of 90 more days. So the idea of stabilization without cycling is 90 days for us. The first 30 days are quite important, almost like readmissions to the hospital. But we're looking at a 3-month period and to see that there have not been avoidable ED visits or hospitalizations. There have not been loss to follow-up or difficulty with something. Things have not relapsed is what our hope is. The services that we're looking at, we are looking at managing complex patients. We are looking at those who are rising risk, and we are looking at building intensive interdisciplinary care plans. We want to do this different from what is the norm because the norm has not worked. We need to change things. We need to be innovative. We need to be disruptive. We need to figure out what it is that's really going to get to the heart of that patient in a figurative sense. We want to make sure we have to be creative. Sometimes we need to go to the pharmacy with the patient. Sometimes we need to go to the other doctor's office. Sometimes we need to call that person, the caregiver out or the family member out in California and do a 3-way, 4-way, 5-way Zoom call. Sometimes we need to have a different team member try to communicate or try to see the different angle from their own perspective. We have this comprehensive assessment from all domains, from all the team members that we have. We can have our visits in different spaces. We have use of the hotline to reduce the communication barrier. And overall, the goal from different perspectives is to reduce the cost or burden, primarily from a clinical standpoint. We're looking to reduce the burden on the healthcare team and the patient and caregiver. We want to reduce everybody's burden and help them feel that they can live freely, a little bit more easily, with better health and quality of life. And of course, because we're a program that needs to be sustained financially, we have to make sure that the hospital system is happy with their overall cost and burden reduction. And so the idea of ED and hospital visits, creating a way of generating reports to show that there has been reduction, is something that you would need for your sustainability plan and your ability to really advocate for the continuation and for greater services for your team. So looking at that intervention just in more detail, I feel like I've explained it a lot already, but where the visit is can be an important thing. Sometimes patients do not like the doctor's office. It is not going to work. Sometimes they need to be in their own home space. If you could do a home visit, if they're close enough by and it's allowable in your own daily work and schedule, that would be great. If it needs to be a video visit, and you need somebody to really have it on a laptop so it's more of a Zoom better experience rather than a tiny cell phone, that could also help for this intervention. You could visit them in another provider's office if that's the only way you can get there. The billing logistics would have to be figured out. ED going into the emergency room, well, that's not your space. That could also just be a type of building rapport and outreach management. Inpatient and telemedicine, also other spaces of places, just to really don't be set in the office visit. You may have to be flexible. The idea of what type of visit, we have the first visit, which is much more comprehensive, and then those follow-up subsequent visits based on the care plan that we've created. And then that kind of transition goodbye visit that really wraps up and is more of an educational reminder of how coaching of how they should continue their work, their lifestyle. And then that idea of setting goals, modifiable goals that are concrete that you can track as a team over time so that everybody is in agreement with how the vocabulary and language is in communicating about where the patient is along this progression of progress. And then the idea of how frequently do you see the patient? Is it every 3 weeks? Is it every 2 weeks? Is it every 1 week? Is it 1 week plus a phone call? That kind of dosing adjustment will be based on your concrete plans and where you are on your kind of progress of the intervention. The 10 M's is just something that we came up with our whole team involved. You can create your own or you can borrow ours, but 5 M's in geriatrics is typically what we practice with the American Geriatric Society, but we also have these kind of more psychosocial supplementals that go along with it. How motivated is a patient to really follow with your plan? and it usually is in conjunction with what matters most to them. Mental health services linked to mind as well, but to really focus on is their depression really interfering with their ability to follow through? Medical decision making and really advanced care planning. Also going with in the context of their chronic diseases, what is the status there? And then that kind of care coordination, which is a huge thing that we realized in working with our patients, being able to maintain their care, transportation, scheduling, organizing, calling for appointments, calling for visits and labs and imaging, and also just following up. When do you have these appointments and primary care, preventive care criteria that have to be done? And then another M that is actually extremely important that not always we focus on is that money. What is their finances? What is their health insurance? Money, Medicaid, Medicare. And often that's linked with medications. How do you pay for these things? How do you pay for these services? Do we need to make adjustments? Do we need to apply for Medicaid? Do you know how to apply for Medicaid? What is a Medicaid spend down? What is a trust fund? All of these things. So number two, the hotline. And the hotline is something that when we started it, everybody said we were crazy. But I will tell you that having a 24-hour, 7 days a week hotline is not that bad. Your patients will respect, most of the time, they will respect that, the after hours, but they will call because they need something. And this is the unmet need that many programs aren't able to provide. And this is something that you as an intensive ambulatory care pilot could do. So this idea of direct communication. It's a hotline that rings on all of our team phones. There's ways that you can set up a hotline to just ring on people's shifts. But we felt that this as a team was much easier because the medical providers and the social workers and the administrative assistant, we all pitch in. And this is a very big team effort. This is almost like a team bonding kind of effort. So it goes along with our stress levels and how we move through the work day, but we balance each other. The intervention, the third piece is how often we meet. You have to meet with your team multiple ways in the team huddle, to really review your census in the overall patient huddle, to review the transition and how they're moving through the progress piece of your program. And then looking at your process, there's a big QI component, your process meetings, how do you improve, how do you evaluate? And then in general, your innovative kind of piece, you have to keep hold of where your passions are and where team members' interests might be, and how do we keep that in the context of our patients. You have to allow your team to expand. You need to allow your team to grow and use the best of their abilities. Everybody in our patient had asked, are you, oh, I didn't change it. So you have our team enhanced clinical skills. So apologies. So you want to allow, we have partnerships, collaborations with Patient Priorities Care. We also had mental health specialty training for our social worker, DEI training for our whole team available. And then other QI initiatives and projects, as well as other ideas. So the idea of being able to be flexible, accommodate the passions and interests of your team is important. And so prematurely, this is a slide of, so you're like, a patient had when we were trying to describe what Align was, he had said, oh, so you're like the Avengers, they call on you when things get tough. And we had that as a joke for quite a while. But the idea is every team member you have, whoever you have, because not every institution will have the same availability. You take what you have and you see what you can do with it. Every team member has their own special power, their special interest, their special talent, and you use that to the best that you can, because what you have is better than before, better than nothing. With your framework of innovation and aging and vulnerable patients in mind, you will do better than the baseline. I strongly believe that. I will vouch for that. Come talk to me if you disagree. Our measurement targets, we're looking at clinical outcomes. I mean, the traditional ones of reduction in ED visits, hospitalizations, length of stay. Those you will always have people who are very interested. And then the patient and provider satisfaction. And you want to ask your patients, what did we do wrong? What did we do right? Or basically what it is, how did we help you best? And your same thing with your providers. What is it that you need more from us? What is it that worked? Was it enough time? Did we meet your goals? And then finally, your 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 financial piece, which is part of your business structure, but are we able to have a dent in the cost? And the last one is, can we train others to be this way? Can we train others to really think about this? And so maybe if they don't come into an aligned kind of model, they'll go into traditional practices of their own primary care or specialty, but they carry with them the ability to really think through, maybe my patient's what's working, what's not working for my patient is because of this, and this. I need to change something. I might need more team members. I might need a different approach. I might need to send to another group for a little bit. In COVID, we made a lot of, this is an example of some innovations. We had to stop our home visits during COVID, for example. We had to really expand on our telehealth platforming. We had to really think about what we could do when we were scared and had no idea what this virus was doing to our older persons. And we didn't know if we could go in the house. We didn't know there was no vaccine. And so just the idea of what do we do, this crisis situation, this is where your high-risk ambulatory team will be able to flex because the way that you are set up. Advanced care planning, goals of care, identification of social isolation plus loneliness, which are not the same, and checking in with our patients and managing them. Going back to our model, so this is again how we use our principle, our central aligned embedded high risk clinic to be able to offer support to these many different domains and spaces, and what we've been able to do over the years. It's been pretty great, exciting journey. And so one of our pilots, so I'll just highlight two of our pilots. So this one is the preoperative geriatric surgery co-management pilot, looking at frail older adults, looking at frailty, which is associated with adverse outcomes perioperatively, and looking how do we optimize, before they go into the OR in the hospital, how do we make them a little bit better from our level, non-surgical, before they go in so that they can come out better than what they could have. And so the idea of these assessments, very aligned, kind of heavy, very aligned focus or style, has been very helpful. And this is just a schematic of how we see them in the outpatient setting. We would follow and communicate with the inpatient team. We would have our social work also follow up. They would go into the surgery and they would come out and we would see them again in transitions of care, because this is something that our team has very well practiced. And the idea of transitions in care, another model. So the idea of readmission and having those criteria of being a telephone call and being seen as per Medicare billing requirements and recommendations, but this idea of the readmission to being rehospitalized without having a physician visit, this kind of really rapid decline about into the 14-day mark is the reason why we should have all of these interventions after they get out of the hospital. And so really following through with that, with the aligned model, has been really helpful to our geriatric patients. And then learners. Don't forget about your learners. Don't forget about the generation that's coming up behind you, because we are rotating and turning over quickly. And you need to make sure that you can make the space better for those behind you with your own leadership and your training. So we have medical students who have a half-day experience with us. There is some pre-reading and self-study. If you want to reach out to me for any of the materials, they come and observe and work with us. We have them think about things through. We have them do fishbone diagrams. We have them do, make them write a haiku poem, but we have them do things in creative ways, because we need our providers to be flexible and creative in how they make and meet these goals and plans for these high-risk patients. And then we also have fellows that work with us, residents and fellows, and they have a longer experience and they manage their own panel. You want hands-on. Everybody wants hands-on experience, and to be able to witness not just that clinical component, but this is a model that really needs the administrative. You have to understand the administrative side. You have to understand the protocol side, the QI side, to be able to make it work. And so we have them experience all of this. We have them do literature review. We have them participate in quality improvement projects. And then also chats for change, a DEI kind of immersion as well, just to let them understand their population that they're looking at for high risk is different from what they may be in if they're going into a specialty. It will be different, and they need to know these differences. All right. Oh, I thought I only had 2 pilots, but these are a few more. So this is the emergency room asking for, when they ask for help, they come and ask you, you can build a pilot around that and say, I'm going to help you think about patients who are not well connected to their primary care provider. How does Align get that, build a rapport back with the primary care provider. And that will be through your asking questions with the PCP. You got to talk to everybody, and be able to understand what it is that that you need to do to get them there, to get them stable and continue to go back to their primary care provider instead of the emergency room. Because we know the emergency room is not a primary care practice, despite what some patients may think. All right, so this is my last, I believe, almost last slide, looking at the progress of Align over the years. From the very start, 7, 8 years ago, we just had a small team. We didn't even have a doctor. I wasn't here. And then adding on these team members throughout the years, adding on an advisory board, adding on in stakeholders, adding on different surgical groups of interest, different champions, the renal transplant, the surgery co-management, adding on telehealth services, other team members, other clinicians, expanding our practice, getting more buy-in from the health system to support our work, and then just really continuing to pivot and continuing to move and grow. There is never a stable time where you are always the same. If you are going to practice an innovative model for older high-risk patients, it will continue to change as much as the population changes. And you know from the slide from before, it is always changing its shape. So you have to be there, and the type of team members you want to keep are those who are able to embrace that flexibility and embrace that innovation and be brave and keep moving forward. So with that, healthy aging, let's get there through innovation. Let's try these different models of care, not what you're used to. Keep stepping outside of your box as far, far away as you can. Fly if you can. And these two on the left are kind of just stock images, but the one on the right is actually a patient of mine. And I loved his t-shirt, and he gave me permission to post this. I'm not getting old, I'm becoming a legend. And so with that, I thank you. I thank all the team members who have been a part of this really long process. It's been very exciting and a lot of fun. And I thank you for your attention, and I wish you all the best. Take care.